So welcome to today's presentation. Today's we are doing pediatrics. Pediatrics. This is the second presentation or tutorial number 2. All right, let's begin. A 2-year-old child is brought to the emergency room. Again, emergency room. So always, if they ask for treatment, you should know what to do. With cyanosis. Now, when we say cyanosis simply means bluish discoloration. If you have jaundice, that is what? Yellowish discoloration. But this is what? Cyanosis, that means oxygen is not sufficient, isn't it? So, they brought the child to you at 4 a.m., cyanosis, and there's severe respiratory distress. It's obvious. If you're having cyanosis, what it means is that you are not breathing very well. So, you're going to have a respiratory distress. His mom says he has been cyanosed since the age of 8 months and frequently squats while playing. So this information, cyanosis and the fact that he squats during playing, should tell you or should point your mind towards a particular diagnosis. Squatting. Now, when you squat, you are trying to be in a form of a football, okay, in a form of a football. So, and when the person squats, the person feels better. The person's breathing becomes better. So that's like a relieving factor when the patient squats, and that is always an indication for a pathology of the heart. It's a heart defect. It's a heart defect. So as we go on, we'll look at the possible heart defect they could be talking about, or we could be referring to over here. So it's a heart defect, or basically a heart defect. All right. So what is your likely diagnosis? What is your likely diagnosis? And of course, over here, you are thinking of what? Tetralogy. Sorry, yeah. Is it a tetralogy? Yeah, tetralogy of Fallot. Yes. So that is what you are thinking about. Tetra meaning 4 defects are present. 4 defects are present. So there's an assignment for you guys. Go and look for the defect that are found in tetralogy of Fallot. Tetralogy of Fallot. Some say Fallot or Fallot. We also call it hypercyanotic spell. Hypercyanotic spell. Hypercyanotic spell. So that is our likely diagnosis. It involves 4 defects. So go and look for those defects. List 2 factors that may have precipitated this condition. 2 factors. So look at it. Somebody is having a problem with the heart. So basically, there's a problem with the right ventricle. There's a problem with the aorta. There's a problem with the ventricles. So you ask yourself, what 2 factors could precipitate this condition? And one, when somebody is having an infection. So one infection. So if you have an infection, your body is trying to compensate for a whole lot of things. So it will try to work more. And the moment you begin to stress the heart, definitely you begin to experience this cyanosis or this hypercyanotic spell. So 1, infection. 2, dehydration. So when your child is very dehydrated and is suffering from this condition, then trust me, the child will start showing symptoms of this hypercyanotic spell. And of course, crying. Because crying will put stress on the baby, and that alone can precipitate this condition. Then when you have exercise, so this particular question, when the patient or when a child is playing or is exercising, then it's likely that the child can develop signs and symptoms of hypercyanotic spell. Hypercyanotic spell. And of course, we have a bowel movement. Bowel movement. Bowel, someone say bowel, so bowel movement. Bowel movement or bowel movement. So all of these things are factors that can precipitate this condition. So put it at the back of your mind. Anything you will do that will put stress on your heart is a factor. Anything that you do that will put a stress on the heart. Anything. All right. Now, briefly outline 4 important findings that may be elicited. 5 important findings, 4, that may be elicited on physical examination. So now your patient is suffering from hypercyanotic spell. What findings are you going to see physically? What are you going to see? So 1, you are going to see a poor growth. So these people, they don't grow very well. So poor growth. And anytime you have cyanosis, that means there's what? Hypoxia. And that hypoxia can lead to what? Finger clubbing or decretal clubbing. So look for the meaning of what? Clubbing. As in clubbing, C-L-U-B-B, clubbing. So it's when, basically, when your, how do you call it? Your nail bed begin to raise, or the nail begin to raise, and don't worry, you look for the meaning of it, okay? Look for the meaning of it. It will stick better. So clubbing, of digital clubbing. Then again, you could experience an ejection systolic murmur. Ejection systolic murmur. And you can see a very loud S2 or second sound. Very loud second sound. Of course, you can see cyanosis. You can see tachypnea. That means the person is trying to breathe in faster to compensate. So, yes. So we have what? Tachypnea. Or tachypnoia. So tachypnea, basically. So all of these, you can mention them as your important findings on physical examination. All right. 3 investigations you will do to justify. This one, I will not mention it. Some of you should mention, then I will continue with the rest. So yes, everybody's going to mention one. So mention yours and be free. Mention yours and be free. Echo, good. So keep quiet. Loretta. Dr. Loretta, mention yours. Dr. Viv, mention yours. I hope you guys are here with me. Okay. So apart from echo, you want to do what? Your ECG. Then you also want to do what? Chest X-ray. Then you also want to do what? Your full blood count. FBC. Full blood count. Then you want to do a septic screen if the person is febrile or the person is is having temperature. You want to do what? What to call a septic screen. Then you want to do arterial blood gases. So do all of this. So this will tell you the oxygen saturation. So you want to do, that's the arterial blood gas. It will tell you the oxygen saturation. The chest X-ray will tell you the state of the lungs. The echo and the ECG will tell you the state of the heart. And I'm talking about the echo will tell you exactly what the defect is. So you don't joke with it. So very, very, very important. So these are your investigations that you would like to do. All right. So we have a 3-day-old baby is brought to the emergency room with a history of jaundice. Again, cyanosis means bluish discoloration. Jaundice means yellow discoloration on the skin and the mucous membranes. So that has progressively worsened over the past 48 hours. So you will meet these things a lot. And even on Viva, they can ask you this question. So don't take question on jaundice lightly. It comes a lot. It's a high yield topic. So if you have the opportunity to study the topic, learn it very well. Good. So back to our question. So 3-day history of jaundice, which has worsened in the past 48 hours. So you start asking yourself, what are the possible causes of jaundice? First of all, you ask yourself, what are the different types of jaundice? So you should go and learn them. So jaundice, you can have the prehepatic, the hepatic, and then the post-hepatic kind of jaundice. And again, under another classification, we can have the conjugated and the non-conjugated or unconjugated. And again, you can have the direct jaundice and an indirect jaundice. So all of these things are all forms, or they are all various ways of classifying jaundice, and you need to know them. They need to be on your fingertips. So when do we have a prehepatic jaundice? When do we have a hepatic jaundice? When do we say we have a post-hepatic jaundice? And in all of these things, what is the ratio of the indirect and then direct, bilirubins? What are they? Conjugated and unconjugated, you need to know them. You need to know, they need to be on your fingertip. You need to rattle it, because you will meet it for sure. You will meet it for sure. For sure, you will meet it. So you need to understand these things. And when you understand these things, then you are okay. Then, so now if you know the various types, like the prehepatic, the hepatic, then you have to ask yourself, what are the possible causes? For example, in prehepatic, you know that you could be thinking of what? Something relating to what? Hemolysis. Because in hemolysis, that means that the blood is not going to the liver. So what? Hemolysis. Then with hepatic, you start asking yourself, diseases of the liver that can possibly lead to what? Jaundice formation, as simple as that. So all of these things will direct you to a differential. Because looking at this question, nothing much has been given, apart from the fact that the person is what? Is jaundice. Nothing else has been given. Nothing else. So you can't say, then this is the definite answer. No, you cannot. You cannot. You can only have what? A differential diagnosis. Case closed. All right. So now let's move to the questions. 2 important differential diagnoses. 2 important differential diagnoses. 1, hemolytic disease of the newborn. Very important cause. Hemolytic disease of the newborn. And this can be the ABO or the resource incompatibility. The ABO or the resource incompatibility. You remember when we, medical school, or those who have been following me on CROC 2, you remember we talked about the ABO incompatibility and then the resource incompatibility when the mother is resource negative and is giving birth to the second or third child. Very, 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 very important. And we talked about them. So please find time and read massively on jaundice. And to narrow it, read on hemolytic disease of the newborn. Talking about the ABO and then what? The resource incompatibility system. All right. What other differential can you think of? You can think of what? Neonatal sepsis. So infection can lead to what? Hemolysis. Infection can lead to breakdown of the red blood cells. That can lead to release of the bilirubin. This bilirubin will not lead to what we call what? Jaundice. All right. Then we can have gene 6PD deficiency, glucose 6-phosphate deficiency, gene 6PD deficiency. It can also lead to what? To jaundice. Then you can think about red cell membrane defect. So red blood cell, the membrane can be defected. So when the membrane is defected, it can lead to what? To bleeding, or it can lead to what? Hemolysis. It can lead to hemolysis. So all of these things can lead to jaundice in the baby. Now, because of the age, 3 days, you can't say malaria, because malaria can also lead to what? To jaundice. Take note, malaria, severe malaria can lead to what? To jaundice. It can lead to hemolysis. It can eventually lead to what? To jaundice. So please take note of such stuff. All right. Now, based on your diagnosis in A, so whatever I'm going to talk about here, it must be connected to a briefly outline 4 important points you will obtain from the history with justification. With justification. That means you must tell us why. Why? So this again depends on your diagnosis. So don't go and write, for example, hemolytic disease of the newborn, then start writing about malaria over here. No, don't do that. No. So based on your diagnosis in A, briefly outline 4 important points you will obtain from the history with justification. So for example, if we are thinking about hemolytic disease of the newborn, what are some of the questions you would like to ask from the history? 1, you want to find out about the blood group of the baby and the mother with antibody screen. Again, since you're talking about hemolytic disease, you're talking about HB rhesus incompatibility and Abo incompatibility, you want to know the blood groups of the mother and the baby. And of course, the antibody that has been screened. For example, people with negative, they sometimes have to screen them or give them antibodies to help the woman, so that the baby coming will not have that effect. So very, very important. So 1, you want to know what the blood group of the baby and the antibody screen. So apart from the blood group, you want to know what the rhesus status. So the rhesus status can be positive, can be negative. So you want to know. Very, very important. You ask your mother, what is your rhesus? So it can tell you, oh, I'm B positive, I'm B negative, or I am O negative, A positive. That is telling you about the rhesus. Very good. Then you want to look at, for example, the GSPD fluorescence. You want to do what? You want to ask if they did GSPD screening. If they did GSPD screening. So very, very important. Very, very important. Very, very important. Then neonatal sepsis. That means you want to look for what? For blood culture. You want to look for what? Blood culture. Was blood culture done? Very, very important. So these are some of the things you might want to what? Find out. And in exams, if whatever you are given is different from what is in the diagnosis, you are wrong. You'll be marked wrong.
Okay.
Just a second. Good. So again, based on your diagnosis, you mention the important point, and then from the history, then you just talk about it. That's all. So HB, hemolytic disease, you want to know if you want to know the blood group, and then again you can even find out if the first child, the second child, the babies, how many of them are having. You can ask all of these questions. Very, 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 very what? Important. Okay, very, very what? Important. So I believe we have dealt with this particular what? Question. So let's move to the next one. For each of the diagnoses, indicate the confirmatory or the diagnostic test. Again, we're having it. It's almost like the question B, isn't it? Almost like it. For example, if hemolytic disease of the newborn, again, you want to, the confirmatory test is what? Is grouping and cross matching. So blood grouping of the baby and a blood group of the what? Of the mother. You want to know it. So that is a confirmatory test that, oh, indeed, there was what? How do you call it? Hemolysis. Very good. And again, for GSPD deficiency 2, the confirmatory test is what? Is GSPD screening. Sepsis 2, you want to do what? Blood culture. Now, sorry, for the neonatal sepsis in the question B, the history, you want to find out if the person is having temperature. Very important. Temperature, not blood culture. Because blood culture, you can't find out if the person has blood culture or not. So you must find out of what? You must find the person having a temperature. Very important. Temperature. Aha. All right. Good. So at least these you can mention them. So again, from your diagnosis, you have to do all of these things. 2 interventions for the management of jaundice in this baby, with 2 complications of each intervention. So again, we are going to talk about what? About the interventions that you would like to take, and possible complications that you are likely to encounter. Possible complications that we are likely to encounter in this baby. So again, usually we have 2 basic ones. Please know them and be free. We have the what? The phototherapy, and then we have the exchange blood transfusion. Phototherapy, and then the exchange blood transfusion. Exchange blood transfusion. These are the 2 most important management that you will do for your patient. Oh, who's calling me? These are the 2 most important things. Just a second. So, like I said, these are the 2 most important things that you do for what? For your patient. So now, what is now phototherapy? Phototherapy. This is not photosynthesis. So this is called phototherapy. Phototherapy. So in phototherapy, we are using like a light. We use it in the operating room anyways. It's like a light that is focused on the baby. Okay. So that radiation that is upon the baby in the form of light, helps the baby. It helps to remove all the jaundice from or dissolve the jaundice, or it will lower the bilirubin level. It will lower the bilirubin level. It will dissolve it just like that. So very, very important. So you need to know some of how it looks like. Unfortunately, I was trying to look for a picture for you, but I forgot to add it up. So very, very, very important. Now, one of the side effects of this phototherapy is that there can be a lot of water loss from the baby. So there can be what? Dehydration. Dehydration. And the person can also have what? Severe diarrhea. The person can have severe diarrhea. So as you are doing all these things, you have to make sure that you are ready to do your resuscitation or your fluid resuscitation. Very, very important. Very, very, very important. And the baby's skin, blood flow through the skin could also increase. Blood flow through the skin can also increase. Some books will say there's hypocalcemia. So all of these things, you need to note them because they are one of the possible complications when you are doing phototherapy. And then again, like I said, the next one is what? It's a transfusion. The next one is what? Is transfusion. So take note of that as well. Transfusion. Exchange blood transfusion. And one of the side effects of exchange transfusion, you already know them. Some of there can be a reaction. It can be a reaction. There can be a reaction which can lead to a whole lot of problems which you don't want the patient to suffer from. Okay, so reaction is there, allergies, all of these things are all there. So you can mention them and then you are good to go. So please take note of that. And this question they can ask you in your viva, in your orals. Please please be an expert of this treatment, phototherapy, and how do you call it? So now my question now is that when do we use phototherapy? When do we use exchange blood transfusion? That's an assignment for you guys. All right. A 7-year-old girl with newly diagnosed Burkitt's lymphoma involving the jaw and the abdomen is given IV cyclophosphamide. The following day, she develops oliguria. That means few fluid are going out of the body, or the urine is not really that much. So the question now is that what is wrong with this patient? Don't forget, the patient is on what? On chemo. The patient is on chemotherapy. So this actually is a chemotherapy drug that's given for what? For the lymphoma. No, lymphoma is like a cancer, isn't it? It's like a cancer. It is a cancer. So sometimes one of the thing that we've realized is that when you're giving this how do you call it, chemotherapy drug, and you don't give it very well, or you're not very careful, this person can develop a whole type of syndrome, which is what the patient is feeling or is going to be having in this particular question. So let's look at the question and then let's see what they are demanding from us. So what is your likely diagnosis? And people who are under chemo and they are experiencing this kind of symptoms, we call it what? Tumor lysis syndrome. Tumor lysis syndrome. What it means is that the treatment of a tumor is leading to signs and symptoms of the drug that has been used. So you can say they are more or less like the side effect of the drug, but not necessarily the side effect of the drug. No. Not necessarily the side effect, but by the fact that you are giving this chemotherapy, this patient is likely to also develop what's called tumor lysis syndrome. So you have to be very careful when you are treating patients with chemotherapy. So our answer here is what? Tumor lysis syndrome. Tumor lysis, destruction, Lysis. Tumor lysis syndrome. All right. Give 3 reasons to justify your diagnosis. So, based on what I've said, how are you going to justify that indeed this is a tumor lysis syndrome? So, 1, this is a newly diagnosed Burkitt's lymphoma. So, newly diagnosed Burkitt's lymphoma. So, that is one reason. 2, there is what? A bulky disease. When we say bulky disease, this lymphoma is involving the jaw and the abdomen. So again, this is also what a reason. So bulky disease of the jaw and into bracket jaw and abdomen, bulky disease. And 3, receiving chemotherapy. So I mentioned 3 things. 1, new diagnosed Burkitt. 2, bulky disease. 3, receiving chemotherapy. These are my reasons for the tumor lysis syndrome. 4 key features of this condition. Good. So like I said, when people are giving chemotherapy, there are things you need to start looking at for them. And these things are typical feature that is helping you to diagnose this patient as a tumor lysis syndrome. So what are the 4 key features? 1, hyperkalemia. So when the potassium starts increasing, it's an indication that this person has what? A tumor lysis syndrome. So what? Hyperkalemia. 2, hyperuricemia. Hyperuricemia, that means too much of what? Urea. Hyperuricemia. 3. Hypocalcemia, low calcium. Hypocalcemia. Then elevated serum creatinine. Then also have what? Hyperphosphatemia. That means the phosphorus is high. Hyperphosphatemia. So again, hyperkalemia, hyperphosphatemia, hyperuricemia, hypocalcemia, elevated serum creatinine. As simple as ABC. So these are the key features for our diagnosis, or for which we can confidently say that this person could be suffering from tumor lysis, although it is not part of what they've mentioned in the question. But for the fact that the person is under treatment and is receiving chemo, it's very, very important that you note that. All right. Outline two important steps in the management of this patient with justification. Outline 2. So 1, you want to do what? Hyperhydration. You want to hydrate the person very well. Why will you hydrate the person? Now, this person is likely to develop what? Dehydration. This person is likely to lose a lot of what? Fluid. So you want to what? Hydrate very well. So again, hyperhydration. 2, now one of the risk factors or one of the features of this condition is what? Is hyperuricemia. So you want to give allopurinol or urate oxidase. This is going to help us fight against what? The hyperuricemia. Then you want to treat a specific electrolyte abnormalities. For example, if the potassium is high, you want to treat it. If the potassium is low, you will want to correct it. If sodium is high, you want to correct it. If sodium is low, you want to correct it. So all of these things are what? Specific electrolyte treatment. So you have to look at the electrolyte before you can do such cases. All right. Good. Now we have a 9-month-old with sickle cell disease. I forgot to mention the baby that was we said 3-day-old having jaundice. Sickle cell can also be a possible differential. Take note of that. Sickle cell can also be a possible differential. So you also, again, you want to know the status of the parent. The status of are they AA? Are they AS or are they AS? Are they SS? You want to know it. All right. And the child's own too, you want to know it. That's just by the way. So now we have a 9-month-old child with sickle cell disease rushed into emergency room with severe pallor. Pallor means severe anemia, or the person is pale. So, and you can only be pale when you have what? Anemia. And anemia means low what? HB or low blood. Low HB or low blood. But over here, of course, sickle-shaped cells. So definitely, you are thinking of a whole lot of what? Things. All right. So let's continue with the question. What are the 3 differential diagnoses in this patient? 3 differential diagnoses. When I ask you for a question like this, it's easy. Just mention them and go your way. So when I ask you that, what they're asking is that what are the possible causes of the person developing a severe pallor or severe anemia as a result of the person being a sickle cell patient? So you might want to mention some of the complications of sickle cell, which can be differential. So you can mention sequestration or splenic sequestration. So the spleen is undergoing what? Sequestration. 2, aplastic crisis. So it can be crisis, aplastic crisis. There can be hyperhemolysis. Hyperhemolysis. So again, splenic sequestration, aplastic crisis. Sometimes we call it you also know what we call the vaso-occlusive crisis. So this person could be developing what vaso-occlusive crisis. We can have what hyperhemolysis. That means the blood is destroying. Serious destruction is going on. So you can mention these things and you are good to go. You are good to go. So again, these are simply some of the complications of sickle cell. All right. Outline 4 points you will elicit from the history to aid the diagnosis and the management. 4 points you would elicit from the history to aid the diagnosis and the management. So what it means is that what relevant information will you need so that it can help you with your diagnosis and of course with your management. Now you have mentioned differentials. You have already mentioned what differentials. So mention things that are connected to the differentials. Now what I do to get more points, I can mention one from each differential that I mentioned, and you are good to go. Or you can mention 2 from anyone that you feel you are very you have your strong point there, and you are good to go. So for example, you can ask the person, is the person having joint pains? Because joint pains, if you have people with crisis, they come with joint pains. So you ask yourself, is the person having any joint pains? Yes, no. Then you write it down. You ask them again, has the person gone through any stress lately? Because people that, sickle cell patients that are under stress, they are likely to develop these kind of crisis. So you ask, has the person been exposed to too much of temperatures or too low of a temperature? Because if they get exposed too high, it's a problem. Too low is a problem. They demand optimal temperature. So too low and too high, they don't like it. And again, you can ask, have you been dehydrated lately? Do you drink 3 liters of water every single day? Especially for sickle cell patients, they need a lot of fluids in their body or in their system. So again, you will want to find out from the patient, because it's going to aid you in your management. Because for example, if the person is dehydrated, you want to give a lot of fluids. You want to give a lot of fluid. So you want to ask, and again, ask of any chest problem or respiratory problem. Are you having dyspnea? Are you having difficulty in breathing? Ask those questions, because this person, for all you know, could be developing what we call acute respiratory syndrome, which is also some of the complications of sickle cell disease or the crisis. So if you have all of these things, you can go on and go on and go on and go on and go on. You can mention and mention and mention and mention. So just 4 points. That's all. Just 4 points. So this point can help you to diagnose it and your management. As simple as ABCD. All right. And again, whatever point that you are mentioning must be relevant in your diagnosis, or it should connect to diagnosis. If it's not connected to diagnosis, please, you are just wrong. Now, apart from full blood count, they know somebody like Alphonse who always mention full blood count. So now they're taking it out. They say, apart from full blood count, list 2 key laboratory tests you will order for this patient. Laboratory test you order for this patient. So again, now what I do is that if I have my differentials in my head, I know my management protocol, then I think of what test can help me to arrive at my diagnosis. Isn't it? Yes. You will want to know. So one of the things that you need to do is that, because this patient, you will definitely give blood. You will get to give blood because the person is having severe pallor. Sickle cell, severe pallor, they might need blood. So one, you want to do grouping and cross-matching. Grouping and cross-matching. Do it. Secondly, you want to do your BUE and your creatinine. You want to check the functionality of the kidney. Because if blood are not getting to the kidney, my brother, my sister, now wahala. Big wahala. So you want to know the BUE and the creatinine level. Then again, you want to do BF for malaria parasite. You want to do BF or blood film for malaria parasite. Blood film for malaria parasite. You also want to do blood culture and sensitivity, especially if the patient is febrile. If the patient is having high temperature, then you want to what? Do blood culture. Blood culture. Very, very important. So apart from the feedback, there are a lot that you can what? Mention. Again, grouping and cross-matching, BUE and creatinine, blood film for malaria parasite, blood culture. You can mention. You can go on and go on and go on and go on and go on. Now, outline 2 important aspects of the outpatient follow-up care of this child based on the differential diagnosis in A. You see, everything is connected to the A. Everything is connecting to the A. So what will be your follow-up precaution or your follow-up thing that you're going to do? So 1, ensure that, now this person is 9 months old, so you must ensure that vaccinations are up to date. Ensure that vaccinations are up to date. Now we are saying that there could be what? A splenic sequestration. So what you want to do is that teach the parent how to palpate the spleen. Some of you should ask you where's your spleen now. I'm sure there will be a problem. But you should be able to know how to palpate the spleen. It's on your left side. So basically around the let me just say the left hypochondral area, or just on the lumbar area on the left. The lumbar area on the left quadrant. The lumbar area on the left. All right. So you want to teach them how to palpate the spleen. Then you want to educate them on malaria prevention. Educate them on malaria prevention. Then educate the parent on recognition of danger signs. Recognition of danger signs. Like anemia. When a patient is, when you have anemia, generally you are tired, you are weak, you can't do anything, you can be having difficulty in breathing. All of these are what? Danger signs. So teach the patient how to identify these danger what? Signs. Jaundice, when the patient is becoming yellow, she should be able to know. Fever. All of these things she should be able to know. Then encourage adequate hydration. Encourage adequate hydration. Encourage adequate hydration. So these are the things that you will do for an outpatient follow-up care. Again, ensure the vaccinations are up to date. Parents know how to palpate the spleen. Able to educate the parents on malaria prevention, and educate the patient on how to identify danger signs and adequate hydration. You can go on and go on and go on and go on and go on. All right. A 4-year-old child presents to the outpatient department with a 1-week history of a progressively increasing generalized edema. Now, when I say edema, I bore. When I say edema, I get angry. Because somebody like Alphonse will get everything correct under edema. Somebody like Green Life will get everything correct under edema. Somebody like Loretta will get everything correct under edema. Because you know everything about edema now. Now, this is the second similar episode in the last 6 months. Her SpO2 in room is 96%. So again, ask yourself, what major organs am I looking at for? It could be liver, it could be the heart, it could be the kidney, it could be the GIT. That's all. That's all. But you see, again, this is occurring in a child. And we've already established that in children, one of the dangerous causes, or one of the leading causes of generalized edema is what? When you are having what? A kidney problem. When you're having a kidney problem, we'll talk about it. When you're having what? A kidney problem. So it could be what? A nephrotic or a nephritic. If someone having a kidney problem, that could be the reason. So again, when they tell you that, oh, in the morning the face is puffy and then in the night it goes off, you are talking about what? Your nephrotic syndrome or Anasaka secondary to what? Nephrotic syndrome. That's what comes to your mind. Okay, so that's just by the way. So look at the questions and then we're out of here. Outline 4 key points you would like to obtain from the history with justification. Again, we know all the points. You know liver, you know heart, you know kidney, you know GIT. Just give 4 points you want to know from the history. What it means is that if you have these differences in your mind, ask questions about the heart. For example, is the person having any defect in the heart? Or was the person born with a defect? You have to find out from the patient. From the parent. Has it ever been diagnosed of any chronic or any heart defect? Ask the patient. Is any of the siblings having similar condition? You want to find out. Because if it is so, then it could be what? Hereditary. Because if people are having a heart defect, heart defect are hereditary, isn't it? So you want to find out about that. Then you come to the liver. Ask question on the liver. No, for a child, it's usually hard to find question on the liver. For example, if it's a grown-up person, you might want to ask about smoking, about drinking, and all kind of stuff. But a child there, perhaps you would like to just skip the liver. But you can have what? Enteropathy, isn't it? You can have enteropathy. Yeah, if you abuse a drug, you can have enteropathy. But that is just by the way. So now, the liver can be aside. Talk about GIT. What possible can you talk about? GIT. So you can talk about the nutrition. Is the patient eating very well? Is he having kwashiorkor? All of these things you can find out from the which proteins is he? Is he on a well-balanced diet? All of these things you will have to find out. Then you move to the kidney. Ask the patient. Now we say that people that develop tonsillitis are likely to develop what? Post-pseudococcal glomerular nephritis. So you want to ask, is there any history of what? Infection? Because that can also be a reason why this patient is having what? The edema. So you want to ask, is there any recent infection, high temperature, blah, 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 blah. You want to what? Find out. You want to find out. Is the person urinating? When the person okay, this one is from the history, so you can't really ask about urination, because urination you might want to do urine dipstick to check for proteins and stuff like that. So you might want to skip that part at this point, because I look from the history. So from the history, you have a whole lot of things to give. All right. Now, outline 4 key aspects of the physical examination of this child with justification. 4 key aspects of the physical examination. Again. Think about it. Again, think about the heart. Think about the kidney. Think about the GIT. These are all examinations you want to do to help you with it. Now, say the person have generalized edema. You want to check the stomach. Definitely, the person have what? Ascites as well, isn't it? So you want to check for the fluid trail. You want to check the fluid trail. You want to check on palpation, downness, relative downness. You want to check all those are physical examination that you want to do. If the person even having difficulty in breathing, you have to find out. The fact that your SpO2 is 97 doesn't mean that you don't have difficulty in breathing. Hope you know that. So you can have everything good, but you can have difficulty in breathing. So you want what? To investigate. So all of these things are all part. And again, for examination, again, check about the urine. Is the person having difficulty in peeing? And the urine, the last time we talked about the average urine per hour that every human being is supposed to produce. We talked about it. So you start checking. So that's why you have to pass a catheter for such a patient. So something like that, you have to pass a catheter for her. Pass a catheter for her and start monitoring the urine outflow. Check the output. Is it adequate? Is the person having oliguria or anuria? You have to know. And they are all part of the physical examination. You might want to even do auscultation. Don't do auscultation. Because it will tell you, again, if there's fluid accumulation in the lungs or not. So you want to do auscultation of the chest. All right. So all of these things you should be able to know. So definitely So now our specific differential, our lucky diagnosis is definitely what? An attacker secondary to what? To nephrotic what? Syndrome. Nephrotic syndrome or chronic kidney disease. I forgot. With one of the history, you want to ask if this child is taking some herbal medications, because some parents like giving their child or their children herbal medications, and this herbal medication can destroy the kidney. It can destroy the kidney. So you want to add it to it. So herbal medication. Why? Because herbal medication can destroy what? The kidney. Because you put a lot of load on the kidney. So again, know all of these things. Know all of these things. Now they are saying that now you admit the patient, and 2 days later, she develops a fever, that means no temperature, generalized tonic clonic seizures. Now, by now, I know that you know the difference between simple seizure and what, and a complex seizure. You should know. The number of seizuring is one of them. The time is one of them. Then, how the seizure is it? The whole body or it is focal. All of these things you need to. So all of these things will help you to differentiate between a simple and a complex one. Good. So they say after admitting the patient, 2 days later, develop these things. When the blood sugar level is normal, list one important reason for seizure in this patient. One important reason for seizure in this patient. So that is why you need to ask yourself, what important reason why there is seizure in this patient? So one point is hypertension. Don't forget, when we talk about nephrotic syndrome, you should be mentioning about what? All of these things, hypertension, and all of these things can have effect in the brain. Hypertension can have effect in the brain, which can what? Possibly lead to what? To seizure formation. So the reason for our seizure is what? Hypertension. Hypertension. All right. And of course, you know how to treat hypertension. So what medication might be used to immediately abort the seizure? Include the route of administration. Okay. So over here, you can use either IV or rectal diazepam. Either IV or rectal diazepam. IV or rectal diazepam. So that will be your what? Your management for the seizure. And again, let me ask you, what is the definitive drug for this patient if you are thinking of a nephrotic disease? Who can remember? Oh, who can remember? Anyone can tell me?
Diazepam.
No, I'm talking about the seizure. So I'm talking about the nephrotic syndrome. In a child, what drug will you give for a nephrotic syndrome patient? The ideal drug to give.
Is it a diuretics?
No. Yes, Loretta, say something. No, guys, come on. We talk about it. The single most important drug for children having nephrotic syndrome. Guys, we talked about it the last time. Prednisolone. Prednisolone. No, it is on this platform. You even ask a question on prednisolone.
Oh, yeah, yes.
You now ask a question on prednisolone. So please.
Yeah, for the Friday, yeah.
So don't forget it. So nephrotic, never forget it. It's very, very good. See, the result has shown that it's very, very good. So we use it a lot. For children with nephrotic diseases, we use it a lot. Then you cannot start talking about your lasers and whatever. I mean, the furosemide and whatever. No. But the ideal treatment is what? Is prednisolone. And this question they can ask you in Viva. So a child comes to you with a swelling of the face and which gets better in the evening and stuff like that. What will be your single most important treatment? Don't go and mention lasers because you're thinking of you want the fluid to go. No. Biko no. So you do what? Your prednisolone. Very, very what? Important. Very, very important. All right. Okay, so ladies and gentlemen, this is now to the end of our presentation.